Good morning and afternoon to everyone that has logged on today. We're seeing quite a few of you on the line, and we expect a few more to join us in the coming minutes. We thought we'd just get started and have begun the recording, and just wanted to give you a very warm welcome for those of you joining us today, and also those of you that will be accessing the recording at a future date. My name is Eva Ross, and I am the Director of the Country Support Team here at Family Planning 2020 in Washington, D.C. But more importantly, I'm your facilitator for today's webinar on mobile outreach services, addressing inequities in access to family planning services and commodities. And I'm very pleased to host this webinar as is FP 2020 on behalf of the IBP HIPS task team. For your reference, today's event is the fifth in a series of high-impact practice webinars that highlight service delivery practices identified and developed by the HIPS partners. This webinar will comprise of 3 presentations, during which panelists will share their insights and experiences while they implement these mobile outreach services in very diverse settings. A couple of housekeeping things to mention. Please make sure that you take a look and download the handouts for today's webinar. These are located in the handout section on the control panel to the right of your screen. You'll see their dashboard, questions, handouts, and the chat function. And as we make our way through the presentations, I really would like to encourage you all to type in your questions, and if you are directing it to a specific speaker, please do that in the chat box as well. And you'll find that on the right-hand side of your screen in the control panel. As we go through the presentation, we will collect the questions throughout, and the panelists will answer these questions from the audience at the very end. Next slide. Today's speakers are Maggie Farrell, who is a health officer and the private sector team leader in the Service Delivery Improvement Division within USAID's Global Health Bureau. Tom Elam, the Outreach Channel Director at Marie Stopes International. And also Ibrahim Muhammad Ibrahim, who is the Executive Director of Planned Parenthood Federation of Nigeria. Next, please. Before we get started with today's presentations, just wanted to share with you a little bit about FP 2020. As many of you that might be familiar with us, we wanted to share these 4 cross-cutting initiatives because we really see the importance of the HIPS and promoting these HIPS very widely. As you can see from the screen, we really see that FP 2020 can only succeed in delivering results by supporting and magnifying the efforts of global and country-level partners, such as all of you participating in today's webinar. And we also play the role of convener and facilitator while focusing on catalytic actions that are directly linked to the achievement of FP 2020 goals. So in order to have the most impact over the final 4 years of the FP 2020 partnership, we're prioritizing our efforts on these 4 cross-cutting initiatives: driving country-level support, the promotion of data use and performance management, sharpening the focus on global advocacy rights in youth, as well as facilitating the dissemination of knowledge and evidence, including HIPS like the one we are discussing today. We're committed to ensuring that FP 2020 focal points in country, as well as other partners, have the knowledge and evidence readily available. Next slide, please. And now let me turn it over to Maggie. Please join me in welcoming her, and she will start us off by setting the stage from a global perspective. Over to you, Maggie.
Hello, everyone, and welcome. Today I will give an overview of mobile outreach services. I'll describe who this model is used by and who it serves. I'll touch on some of the components of the models and the variations in the models, and then we'll discuss costs, impact, sustainability, and value for money. Next slide, please. Mobile clinical outreach is a way of bringing services to remote and underserved populations. It can serve a lot of clients with a full range of methods in a short period of time. Most countries face challenges in getting long-acting reversible contraceptives and permanent methods to clients because of human resource shortages, lack of clinical training, or lack of confidence in doing procedures due to low volume. There can also be a lack of clinical infrastructure for remote populations and those peri-urban slums that have seen large population growth, and the public sector infrastructure hasn't really gotten out to serve all those people. Without mobile outreach, many poor and rural women may have access to only a limited range of resupply methods. Opportunity and travel costs may make traveling to the nearest public clinic or hospital very difficult. Mobile outreach requires demand-side efforts to ensure clients come to the mobile outreach event and understand the methods that are offered. This is done in a range of ways, including promotion and advertising at the clinic itself, working with community health workers or other community structures, or working with existing community communication systems, such as the town crier. A note on sustainability. Some countries may have mobile outreach as a component of their family planning program, like Nepal, Peru, or parts of Canada, as they have made the decision that they cannot build out clinical capacity for long-acting and reversible contraceptives and permanent methods in all areas due to distance, geography, and cost. But they are committed to making itinerant services available for these methods through this channel. Donors may support NGOs or governments to do this work. Some governments contract out NGOs, for example in Papua New Guinea, Tanzania, India, and some governments run their own mobile outreach services, including Nepal, Peru, India, and Tanzania. Next slide, please. So what does service delivery look like? This slide illustrates some of the different models. There's a classic model that includes nurses and or midwives, a vehicle, a driver, and a doctor. They bring equipment, contraceptive supplies, and can set up in health posts, schools, or in tents. There's a lighter model, such as the Marie Stopes Ladies, a model that is a nurse or midwife who can provide LARCs in peri-urban areas, who can travel by foot, auto rickshaw, or boat, including providing services in women's homes. There's a dedicated provider model, where an NGO may post a provider or rotate one provider who can provide LARCs and or PMs in public sector facilities. There are public sector models that include camps or mobile teams that access remote populations, such as in the high mountainous regions of Nepal. Services can include family planning, maternal child health, HIV/AIDS, etc. But for the purposes of this presentation, I am solely focusing on family planning models. The demand side, including the use of community health workers for info and turnout, interpersonal communication, and promotion of the outreach day, are very important components of this model. Please see the mobile outreach HIP brief that is posted as a handout number 4, yes, for more details on these different models. Next slide, please. So mobile outreach is a blockbuster service delivery channel. It is perhaps the most productive of all service delivery channels, and its aim is to reduce barriers to access, maximize method choice, and extend the reach of the existing health system. Most of the health systems we are working with struggle with making LARCs and PMs available, particularly in rural areas. Here you can see two different types of mobile outreach models. The one above is the traditional model I spoke of in a rural area to a small clinic with limited capacity to provide LARCs or PMs, but typically offering a range of short-acting methods, pills, injectables, condoms, possibly emergency contraceptive, lactational amenorrheal method, and standard days method. Some models incorporate a skills transfer component where the mobile team builds clinical capacity of the public sector and at some point leaves them with skills to provide the services themselves. This model may be slower and less productive initially as bottlenecks such as lack of commodities, equipment, and personnel shortages are worked out and solved, and until providers are trained and really feel totally confident in their newfound clinical skills. The one below is a lighter model with a mobile nurse in peri-urban areas where a nurse can offer LARCs and short-acting methods. This one goes to health clinics and health posts on immunization days in Zanzibar, and as mentioned, can also go to women's homes. if they can't leave their homes. In some countries in the Sahel, where populations are extremely dispersed and women face mobility challenges and service delivery infrastructure is extremely limited, we are utilizing mobile male nurses on camels. Next slide, please. Another mobile outreach approach to improve access to LARCs and PMs, which requires more time and skill than short-acting methods, is dedicated providers. These can be either seconded providers or mobile providers who are brought in to give a boost to current service delivery offerings and help the staff at high-volume clinics or hospitals. This is what PSI did in Zambia, drawing upon retired government midwives, though many partners do program this. Government personnel, doctors or nurses could also support their own mobile providers to visit different clinics on a rotating schedule to provide additional or extended service offerings. Right here in Washington, D.C., hospitals brought in Planned Parenthood to conduct client counseling since their own staff were too busy to provide this important client service and interaction. Next slide, please. Now let's discuss the cost, value for money, impact, and sustainability of these models. Mobile outreach is perhaps the most strategic and flexible use of limited human resources, equipment, and commodity resources. It's low cost. One NGO averages about $100,000 per team for the full model. It's less for ambulatory nurses and midwives who can provide IUDs and implants, and it's constantly improving efficiency through data analysis and quality improvement processes. The literature shows it can be 1.4 times more effective than static services. It's high volume, so the cost per CYP can be less than static services. It strengthens health systems by building existing Ministry of Health staff clinical competence, better counseling skills, as well as management of adverse effects, as well as increasing local NGO staff skills of local folks in the countries. It delivers and maintains skills more efficiently. That's from the literature from Lynn Bakamjim, an article she did in 2008. There's lower complication rates due to high level of expertise from high volume of procedures. Clinicians who do a procedure infrequently have higher complication rates generally. There's evidence that it stimulates demand for LARCs and PMs through increased provision of information and accessibility of quality services. It can be contracted by ministries of health to expand access and equity. It's convenient for those who have limited access and cannot afford transportation costs and the opportunity cost associated with seeking faraway services. It addresses cost barriers to service, user fees. These are important barriers for the poorest of the poor through subsidization and free services. Next slide, please. It addresses inequities and can enfranchise the underserved. It improves quality through broadening the method mix, one of Judith Bruce's dimensions of quality. It increases use of contraceptives. This is from an article by Mulligan in 2010. It has greater potential to affect maternal mortality and child mortality due to remote populations who are with inaccessibility of infrastructure, trained personnel, by preventing unintended pregnancies. Here's some of the evidence from one of the mobile outreach programs that we're funding. In 2012, 42% of the clients at one NGO lived on less than $1.25 a day, so you can see it's really serving the poor. 41% were new to FP in Sub-Saharan Africa, 57% in South Asia and Middle East. 59% were switchers from short-acting methods in Sub-Saharan Africa. So you can see it helps switchers get on more effective methods, and it also serves the poor and really has potential to increase prevalence. We actually have data in several countries that have national scale of mobile outreach that prevalence has increased by sometimes 2 percentage points, modern contraceptive prevalence. It helps address the shortage of healthcare personnel that is rampant in many countries. It creates public-private partnership coordination by planning together, data sharing with NGOs, NGOs sharing their data with the public sector. And in this way, it can convince the public sector of the latent and stimulated demand for these kinds of services. Sometimes ministries of health don't believe there's actually demand for these services because there's no access, and there hasn't been a lot of demand creation because there's no access. So when you bring in a mobile team and you demonstrate that people are lining up to get these services, it can be very impactful in terms of the Ministry of Health understanding that there is, in fact, demand. And there's emerging evidence that it's an important model for conflict and post-conflict services when the public sector is not functioning. We're funding this in Nigeria in the north, some of the areas that Boko Haram has been active in, and there's also evidence of this in a journal article from Uganda. So I encourage you to take a look at the HIP brief, the High Impact Practices brief, prepared by our office to learn more about this very impactful and low-cost model. Thank you.
Thank you for your insights, Maggie. We're seeing some questions start to trickle in, and I'd like to encourage you, as the presenters share their insights, to type in your questions in that question box to the right-hand side of your screen. And next we'll hear from Tom Elam from MSI, who will be presenting a couple of implementation examples. Go ahead, Tom.
Thanks, Eva. Next slide, please. So I'll be sharing with you today some of the aspects of our outreach success model. These are the rules and recommendations that we put together to achieve outreach excellence here at MSI. First and foremost, we have to understand what the purpose of our outreach channel is. And here at MSI, we have a very clear vision, which is about expanding access and choice to high-impact clients. For us, high-impact clients are clients who are not currently using family planning, who are poor, who are young, or who have no other means of accessing family planning. And we do this in a high-quality, cost-effective, and measurable way. Next slide, please. So it might surprise you, as the Outreach Channel Director of MSI, I'm going to go through 3 slides where I'm not going to mention outreach whatsoever. And that's because any outreach excellence must first begin with understanding our market and understanding our client. Next slide, please. Next slide again. So the first step that we take in terms of outreach is to analyze our market and really understand the health context. This helps us understand where the need is greatest for outreach, where there's high unmet need, but it also helps us understand where government or other partners already operate and may already be providing these services. And that helps us ensure that we enhance and complement rather than duplicate in the market. Next slide, please. Once we have understood the market and selected areas of intervention, we begin to look at our clients. At MSI, we're lucky to have the behavior change framework, which you see in front of you, which is a framework we use to help us understand an individual or population and their journey from lack of awareness to actually advocating and promoting voluntary family planning use in their community. At each stage, there are factors and barriers that might prevent them from transitioning to the next stage or even staying at that stage. And by understanding these and truly understanding our client, it makes sure that we can not only provide the information that they need and require, but also services and support that really suits them. Next slide, please. And the next slide. So now I am going to talk about outreach, but amongst our other channels, having identified a market need and understanding our client, we don't immediately choose the outreach channel. Here at MSI, we have clinics, we have social franchise, we have MS Ladies, and social marketing, all of which have a great strength in reaching certain client groups. So when we understand the client, we look at each of the strengths of these channels and ask ourselves which is most suited. For example, urban clients with higher income may prefer the convenience of a nearby clinic. Young men valuing discretion may prefer to pay for their condoms at a pharmacy. However, over time we have really found that the outreach's focus on high-impact clients in rural areas is a real niche for the channel, and it's entirely suited to those clients. Next slide, please. I won't spend too long on the models because Maggie's done a great job of giving an overview of the classic, the light, and the dedicated provider or public sector strengthening models. Only to say that once you've identified outreach as a channel, there's no one-size-fits-all. And we look at these models as a general typology and tailor it to the need, making sure that the teams are able to fill the gaps, to complement what is already available, and to provide a service at a level of quality and safety that the clients deserve. Next slide, please. And again, next slide, and one more. So once we've chosen, one back, please. Great. So now we've chosen our model, we know where our market segment is, and we understand our clients. And this is where we start to look at the sites. So the first step to make sure that we complement and enhance capacity is to have discussions with the government and other partners. And we try and always do site selection in collaboration. And that ensures that we reduce duplication. We look at certain criteria. This might include percentage women of reproductive age. It might include where there's limited method choice, or poor transport links prohibit people to access other service delivery points. All of these help us understand which sites we should target and prioritize. Now, all of our models and outreach in general is very suited to low resource settings. However, we do need to ensure that there's adequate infrastructure which won't endanger client safety or jeopardize quality. So once we've identified certain sites, we do pay a visit to make sure that certain things are in place, or that we can put them in place to make sure that the client experience is positive. Now, when we're selecting sites, we always try and prioritize site locations at existing health facilities. This has three benefits. The first is that it reinforces that health facility as a place to seek health services in the community. Second, it helps us reduce operational costs. And finally, it speeds up our ability to set up and begin to give services. Over time, we continually look at our site selection using site-level analysis to continually optimize our operation. Next slide, please. Once we have our sites, we begin to schedule. Our teams put together monthly or quarterly schedules that take into account levels of client demand, but also method mix. If a team is providing short-term methods, we ensure that we have repeat visits every 2 to 3 months. Now that they've got their approved list of sites, they look at these sites and look at the routes between, minimize travel time, and therefore maximize the time that we spend serving clients. And this sometimes involves staying overnight in communities where demand is high, or where the next site might be very close by. All of this is designed to minimize waiting times by arriving on time. Next slide, please. So that's a bit about the supply side. Now I'll talk to you about the demand side. So given that the slides up to now, I've talked to you about creating a consistent and accountable supply to our clients. It's important that they know that supply exists, that those services are available. And we do this firstly by choosing our communication channels. So we're lucky here at MSI to have annual client exit interviews, a client information system, as well as other external sources that tell us about types of media our clients consume. This also lets us know how clients hear about our services. Now, based on all of these insights, we select the communication channels which are going to be most likely to reach our clients. Next slide, please. I should say, if client exit interviews are not available, Lots of organizations such as BBC Media Action or Population Media Center also have really good information on the type of media that clients consume. Once we have our communication channel, we develop messages which are going to be tailored to resonate to particular individuals and populations. And of course, we use the behavior change framework, which I introduced before, to design these messages. For example, in a community with a lot of awareness, but very few people intending to use family planning, we might realize that a lot of misconceptions exist. And in that case, we might use the communication channel of a satisfied user, and the messaging will be around dispelling some of those misconceptions. That's one example. Another example is in a community where there is high level of intention to use family planning, but access has prohibited them from getting these services. In this case, the messaging would be more about where and when they can receive these free services. Next slide, please. We work with communities, and we try always to have the community to conduct advanced awareness generation at the site. Now, this makes sure that most of the clients in that area know the visit is coming. It also allows clients time to discuss with their partners, friends, family about their decision. Next slide, please. And then on arrival, our teams deliver group health education. Now, this employs songs, games, group discussions, anything required to engage clients to make them feel comfortable about asking questions, make sure that they receive all the information they deserve to know. And we make sure group health education covers all methods. It covers dual protection, and it also addresses some of the common reproductive issues that might be experienced in the community. From there, before we deliver the service, we deliver individual private counselling. And this takes into account clients' fertility intentions, their lifestyle preferences, and also medical eligibility. All of this helps us ensure that clients can give their free and informed consent. Next slide, please. Of course, running a large outreach operation with over 500 teams across almost 30 countries is not without its challenges. We've had two significant challenges over the last 18 months. The first, next slide please, is about monitoring of outreach teams. So when we have teams working in remote rural areas, our ability to monitor them is very limited. That means that the operational effectiveness of these teams varies wildly. We have some teams that deliver services on under 10 days per month. Under the Global Fleet Project to improve on those objectives. That, of course, also improves staff welfare, safety, and helps us reduce cost. Finally, next slide, please. Data validation. So, unlike our services in clinics or social franchise, which are usually backed by a financial transaction, in outreach we provide them free. Compounding that is that our record keeping in most of these areas in this low resource context is paper-based and that are then checked by supervisors and the outreach channel leads in country. These are some of the things that we're doing to try and improve data validation and therefore improve our overall data quality. I hope you have found this interesting, and I look forward to any questions you may have at the end of the presentations. Thank you, and back to you, Eva.
Thank you, Tom. Really appreciated you sharing MSI's outreach success model in order to reach or have outreach excellence. Apologies to those of you on the line. I know we had a few technical difficulties during the last slides of Tom's presentation, so I would encourage you to ask questions on those slides if you need additional information. And now let me turn it over to our colleague Ibrahim, who will share PPFN's integrated outreach approach. Over to you, Ibrahim.
Thank you very much, Eva, and a big thank you to Maggie and Tom for really paving the way for my presentation. I'm sharing the experiences of Planned Parenthood Federation of Nigeria in using the mobile outreach to provide family planning and reproductive health services in Ibadan, Nigeria. The outreach was an add-on to our existing clinical model of service delivery called the cluster model, and I will get to that later. Next slide, please. Okay, this is the outline of my presentation, introduction of the cluster model, intervention strategies associated with the model, and to highlight the outreach, and to outline the key drivers and key achievements. Next slide. Right, PPFN introduced the cluster model to increase uptake of long-acting and reversible methods, and also to facilitate effective referrals and follow-up, to enhance logistics management and improve local leadership and buy-in into our program, and also to increase our program sustainability. Next slide, please. Yes, the next slide shows a diagrammatic depiction of the cluster model, which is mainly clinical with some community resource support. It's a model whereby a PPFN clinic works in partnership with 4 to 5 other clinics drawn from the public sector, the for-profit private sector, the faith-based organizations. Basically, the PPFN clinic supports these other clinics to provide family planning services by training their personnel, providing them with the needed contraceptives and consumables, ensuring they have instituted a data management information system that is aligned to the national system, and enhance referral across the facilities within the cluster model. The model also uses existing community resource persons, be them peer health educators, community health extension workers, and other agents that have been trained within the communities for mobilization or for service provision. Now, it's an effort to go further, to further expand access to family planning services, that the model was improved to the Cluster Plus model, whereby an outreach component was added, also a voucher system to take care of those who cannot afford services. Thirdly, to operationalize the task-shifting, tax-sharing policy of the government of Nigeria, whereby community health extension workers were empowered to provide LARC. Also, another addition to the cluster model was the introduction of a mobile application to ensure that stock out in the clinics is reduced. And lastly, working strongly with the community leadership for sustainability of the programs. Next slide. Good. Yeah, so We conduct integrated outreach in 3 days. Each session takes 3 days. Outreach sites were selected using a mapping system to determine the areas with good population denominator and also who lack access to services. The outreach team normally has 2 doctors, 3 to 4 nurse midwives, data officers, and a driver. And prior to outreaches, we do a dialogue with the community to agree on days, venue, and to begin to talk about family planning and clarify myths and misconceptions. Next slide, please. Community mobilization activities usually commence a week before the actual outreach, and sites are assessed to ensure that we identify the location where to provide the services. This may be a partner clinic in most instances, and also the needs of the communities are assessed in terms of other related services, mostly STI treatment, HIV testing and counseling, and malaria treatment and testing, and cervical cancer screening. During the assessment, also we identify facilities that can serve as referral points to the potential clients. Next slide. Well, as part of our preparations when starting this outreach program, the teams, 2 teams, went on a study visit to Uganda, where we learned from the Member Association Reproductive Health Uganda how they were conducting their outreaches. Key elements for a successful outreach from our experience are ensuring adequate supplies, commodities, and equipment, strong involvement of the community, and ensuring their participation where they have the resources to support. This is mainly in the area of community mobilization and sometimes in actual service provision. Other key success factors are training and continuous training of our team members, and ensuring quality of care in provision of services. Next slide. We conducted these outreaches in 5 local government areas of Ibadan, which is a large urban center, but with significant peri-urban slum communities. The baseline survey was undertaken before the commencement of the actual outreach services. After implementation, which lasted April to December 2015, we have seen a significant proportion of poor and vulnerable population taking up family planning services. There was a 74% increase in uptake of LARC, and a huge number of new acceptors were recorded within the 9 months of implementation. Next slide. The next slide shows monthly achievements in terms of new acceptors, continuing acceptors, and total clients reached between April to December 2015. There is a noticeable increase compared to our previous data, and in the month of April, where 8 outreaches were conducted, that month recorded the highest number of new acceptors. The trend shows a progressive decline from April to December, This is probably as we move from the more hard-to-reach populations moving towards the center of Ibadan, the demand for services reduces because there are other points of services. Also, it's also linked to the number of outreaches conducted. You can see October, November, December, where we conducted only 2 outreaches per month. The number of persons reached, it's lower. Next slide. In this slide, we compared the method mix. There has been a huge increase in IUDs and implants. Next slide, please. Now, comparing the outreach to the clinic-based services and also the community-based services provided by the community health extension workers, we have seen the outreach far provides more services, about 5-fold when compared to the clinics, and almost double the community-based services provided by the community health extension workers. And this relates very well to Tom's presentation on value for money, sustainability, and effectiveness. Next slide, please. Some voices from the field. Those either beneficiaries or providers made comments about the intervention. The first one from a nurse saying that at the end of each day, we do a performance review to evaluate what has worked and what has not worked and how we can improve. A community leader said that through community dialogue, our community leaders were sensitized on schedules for the outreach, and after sessions, community leaders pass information to members of their communities. A medical director of one of the cluster clinics who participated in the outreach also attests to the fact that the outreach increased client flow to the clinics, confirming that there are referrals from outreach sites to static clinics, and many of those referrals are for additional services like cryotherapy that were not provided during outreaches. Next slide, please. Okay, these are pictures of some of the community mobilization strategies employed by the teams. Working the streets using megaphones and one-on-one health talks. Yes, this shows one of the teams getting set to go out for the activity. Also a session on group health education in a church. And the last picture is the team getting ready to put their equipment in their bus and set out for the field. I thank you very much for listening, and I welcome questions to clarify the presentation. Thank you very much.
Thank you, Ibrahim, for sharing PPFN's experience and approach. We've been taking note of the many questions that have come in during the presentations, and we'll certainly do our best to answer as many as we can in the next 17 minutes or so. Tom, let's see if the technology is working in our favor, and perhaps I can turn to you. There's been a couple of questions for MSI, especially related around client exit interviews and client follow-ups. The questions around how do you monitor those client follow-ups, especially in cases when there might be complications or adverse events that happen a few days after the outreach. And perhaps if you can also tie in around the powerful tool that you have with the client exit interviews. What other insights are you able to draw from them that might help you improve your outreach programming?
Yep, of course. So I'll start with the client follow-up question. So of course the outreach model does create additional challenges in terms of client follow-up. We have various ways of mitigating those risks. First and foremost, it's about working with the health providers at the facility, at the site, whether they be the government health workers or the people in the community that we work with to build awareness, and make sure that they are aware of potential complications, potential side effects, and know exactly when the team should be notified. So that helps clients know that they have a point of contact in the community even after the outreach team would leave. We also in some countries have call centers which play that role. On top of that, we also reinforce our services with aftercare. So every client is given aftercare information, both verbal and written, and that's reinforced with phone calls in some cases. So we make sure that we phone 24 hours, 48 hours afterwards to ensure that the client is not experiencing any negative side effects and no complications have arisen. So that's part of what we do to manage that. On the client exit interviews, it is indeed a very nice tool that we have. We conduct it across almost all our countries on an annual basis. And we have a set of questions. We take a set sample from each channel, and that allows us to compare our performance on things like equity, client satisfaction year on year. This, of course, is voluntary for clients to answer. We do approach them after they've received the service, and a numerator who is not connected to the outreach team delivers the questionnaire if they agree. And that helps us really zero in on some of the quality issues which we might not capture, making sure that clients are satisfied with things like the cleanliness of the facility, waiting times, and it helps us validate our management information systems data to ensure that if we're recording 25 or 50% of clients being under 25, the statistical sample we take from the exit interviews confirms that we're seeing that in the exit interviews. I hope that answers the question.
Thank you, Tom. Let me take it that the technology is in our favor to ask one more question for MSI, and then we'll turn to questions for Ibrahim and Maggie. Tom, another question for you is, how does the coordination take place between the demand generation team and the family planning service delivery team?
Great question, and I'll take this opportunity to share a bit of history at MSI. In the past, we have had teams that have focused on both the demand generation and the awareness creation and delivering the services. But more and more we're moving towards a model where different teams take care of that demand creation and awareness building. And this allows our clinical teams or our outreach teams who are staffed by clinicians to focus on delivering quality services. So we separate our teams into regions or clusters, and they are all managed by a regional manager or a cluster coordinator. Within the region or cluster, there would be a focal person for the awareness and the demand generation, as well as the service delivery. Now, this makes sure that at the top, that there are conversations happening and there's joint planning going on. Most importantly are the schedules I referred to in my presentation. By generating and developing those schedules in advance, they can be shared with the demand generation teams so that they know exactly where the teams are going, when they're going there, and they can work and stagger their approach in these communities and at these sites to ensure that there is good awareness that the services are coming and there is demand for family planning in those communities.
Thanks very much, Tom. Ibrahim, a question for you. Regarding PPFN's Cluster Plus model, has it been used or applied to other efforts beyond family planning? For example, in other efforts to increase access for certain kinds of services?
Yes, thank you, Eva. Yes, the cluster model has been used to increase access to other services, namely malaria, HIV, STI testing and counseling, cervical cancer screening. It's a model whereby a number of clinics sign a memorandum of understanding with a PPFN clinic. And PPFN clinic supports those other clinics by training their staff, providing commodities, and instituting data management information system, and also facilitate cross referrals across the clinics. We try to get a mix of clinics, a for-profit private facility.
Thanks very much. Maggie, a question perhaps that you might be able to comment on given your mention of PPPs.
Some government facilities, some faith-based organizations.
Maggie, a question to you regarding outreach within the private sector. Someone is asking for additional information, whether there's additional experience you might be able to share given your mention of PPPs during your presentation.
So my mention of PPPs is really, there's two different definitions of PPPs. There's, multinational corporations and leveraging money, expertise, resources. I wasn't talking about that kind. I was talking about a public-private partnership between an NGO in this case and a local district health office or a Ministry of Health region, if you will, and planning together for mobile outreach. Since the actual mobile outreach from the NGO takes place within the public sector facility, often there's a lot of planning that goes on. The public sector team is often incorporated into this team to learn skills. They're taught removals of implants often. They're taught removals of IUDs. As Tom mentioned, they're taught adverse complication management in case anything happens. And also in some models, they're trying to build their skills to actually do the clinical services, to learn, see one, do one, on-the-job training, and also strengthening their counseling skills by modeling and shadowing behavior. So that's the kind of PPP I was talking about, but there are examples. I think the sustainability in the future of mobile outreach is to be able to get governments, as the steward of the system, to finance mobile outreach teams. And we do have, MSI has some examples of this in Papua New Guinea. Tom's very familiar with this because he worked on this, and he can speak better to this than me. But the government funded mobile outreach through Marie Stopes International, through mobile outreach. There was also an example in Tanzania with Canadian CEDA, where Canadian CEDA was flowing the funds, I believe, to the district health office, and then the district health office was funding the mobile outreach teams, practicing managing those contracts, monitoring and evaluation of those contracts, and also flowing the funds, the reimbursement. So those are some examples, and I think in the future, as we move towards UHC, universal health coverage, and social health insurance, we see this as a possibility in terms of governments being able to contract out to mobile outreach teams with NGOs.
Thank you, Maggie. The next question is for all three of our panelists. Regarding youth, the question is around what are any particular strategies or actions within the various models we've discussed today that are used to better serve young people and respond to their needs? Who'd like to respond to that?
I'm happy to. Yep, should I go ahead?
Please go ahead.
Okay, so very timely question, and I think, you know, Murray Stopes alongside every other organisation would say that youth is an area due to demographics, but also some of the weaknesses in our models that we really need to work with as a sector and improve the service, particularly to adolescents. However, we have started to identify some high impact practices, if you will. And we're busy working with certain countries in our partnership to test and refine these. Some of the interesting initiatives that we're testing is addressing some of the values of our providers themselves. So conducting values clarification training with our providers, who in some cases may not necessarily agree that adolescents should receive these type of services. And in this case, we have seen some success as providers realize that consciously or subconsciously they are holding these values, and that means that they're not providing a quality service to the clients. We've also seen some success with really identifying youth-friendly sites. So these are sites which are away from our traditional sites that might be multi-generational, where young people can come and know that they're not going to bump into their auntie or their mum or anyone like that, and that gives them a level of discretion which they feel more comfortable with. And in some cases these aren't highly branded. It's very discreet, it's very low key, and that sometimes means staying for an extra day at sites and promoting these discreet youth-friendly sites on the first day for youth to come to on the second day. But like I say, we very much agree that this is a work in progress. So I'm looking forward to the other panelists and any ideas that they may have, which we can borrow and test together.
Thanks, Tom. Maggie or Ibrahim, anything you'd like to add regarding better access for youth?
Yes, please. Our outreaches did not specifically focus on young people. However, all the service providers that have worked on the outreach were trained on youth-friendly services. But interestingly, from the community leaders, we were informed of a high rate of teenage pregnancy in a particular community, and the community leaders call on us to provide health education and IEC materials for young people specifically. Along the line, we got a partner who supported us with Sayana Press, and that was added to the method mix, and in a way here tried to address the needs of young people. But we are way behind on focusing on young people in the outreach program. Thank you.
So this is Maggie. Let me add to what my colleagues have said. The data coming out of Marie Stopes International's mobile outreach, and Tom can really speak to this more too, really shows that the channel is really reaching married youth, less so unmarried youth, although in some countries that may differ. And I think there's some promising models that we've been funding through our CISPO2 project with Marie Stopes International. One is in Tanzania, where we're going to be running youth outreach, so we're going to see how that goes. It's just beginning currently, it's just begun, so it's in startup. And then, you know, there's the potential. We had a good experience in Senegal and a university, and it seems to me if you put a dedicated provider into a university health clinic and reach out to a larger catchment area, not just the university students, but youth in the community, that might be a model that has some potential for mobile outreach.
Thanks, Maggie and Tom and Ibrahim. I see that we're almost out of time, so I wanted to let you know that because this came in some of the questions as well, we're going to share the webinar recording and this presentation, of course, with everyone who has registered via email. And we'll also be posting the recording on the HIPS website, which you can see here. So please make sure you share this with other colleagues who perhaps were not able to join with us today. Next slide. And of course, last but not least, please do join me in thanking the panelists today and all the various partners that have made this webinar possible. On behalf of the three speakers, as well as the organizers, we want to thank all of you for participating today and for your very insightful questions. And apologies to a few of you in the queue that whose questions we did not get to, but thanks very much for your questions and participation. Have a good day.